This analyzer has a USB printer that you can use to print your results. If you are giving the results in hard copy, you can print it out and submit. But if you have EMR that you don't need to give the result in hard copy, you can PDF, put it in PDF and send to the doctor or whoever that requested for it. So we have other instruments, other blood banking instruments, which includes the blood bank refrigerator. They could have you don't need to have the whole money to open a lab. We will discuss with you and we will help you. We are scientists, but I'm surprised that most of the labs that are doing well in Nigeria now are owned by we need to contact the right persons. Even when you are a scientist and you want to open a lab, you need to contact the right persons that will recommend the right equipment for you. It's not all about going to market and buying equipment. You may have the money to get the equipment, but there are so many things that are involved. Getting equipment is not the total solution for laboratory diagnostics. So you have to ensure that this equipment that I'm going to get, what about the reagents? Can I get the reagents? Are they available? What about the service contract? Because this equipment will one day break down. Do you have an engineer, the company you are buying it from, or the market where you are buying it from? If the machine breaks down tomorrow, do you have a technical support? Do you have an engineer from the company where you bought it from that can service this machine? All these are what we offer in this CL. Thank you so much. And if you have any inquiry, our stands are behind there. You can visit us and we'll give you solution for every problem you have.
Distinguished guests, ladies and gentlemen, please, once again, let's put hands together for this CL. This CL, the only thing you need to do, just pray hard. Let me hit more MC contracts. I will open the lab and invite you to come and equip the lab for us. We have this conference t-shirts. One of the reasons why we are gathered here as not just to only discuss the blood pandemic, is also to give visibility to our society and the profession we belong to. How do we give visibility to the society and the profession we belong to? Is just to acquire this t-shirt. Wear it to church, wear it to party, wear it to anywhere. After all, I have seen people wearing APC t-shirts and tying PDP wrapper to functions. So if you wear these Hbtssn t-shirts to any function, people will see it and they will know that you belong to a profession. Hello. It goes for just 9,000 naira. The quality, you will wash, and it will continue to be like this. This t-shirt is like those village people that drink hospital too far. But that's how people will understand what I'm saying. Buy this 9,000 naira and show people that you attend a conference like this. I have gotten mine. Will you get yours? Will you get yours? Go to the reservation stand and buy one for 9,000 naira. Thank you.
Thank you very much. Welcome everyone once again to our Day 3 scientific conference. Thank you. For your equipment, laboratory equipment, you can go to CCOB Nigeria Limited. They are at the back site for your equipment. Then we also have 6 mechs from all the way from Ghana. Can we celebrate them? All the way from Ghana. He flew from Ghana down to Lagos, flew to Port Harcourt, and came by road to Bayelsa. Please, let's appreciate 6 marks. And please, when we come up here, we have a lot for today. So we'll try and be conscious with our time so that all presenters can present for today and we can close early and go back early. Thank you very much. 6 marks, please. Please appreciate him as he comes forward.
from here. You have the presentation. Yes, can you project it? Good morning, senior colleagues. My name is Elijah Kupa Agri, and I'm happy to be with all of you here. I'm going to present to you on HBTSS diagnostic solutions that will help us to keep blood safe. So the theme of the presentation is HBTSS diagnostic solutions. We say together for a better healthcare journey. We in HBTSS are very concerned about the patient and the medical scientist, as well as the clinician who is managing every patient. And we all want to work together to make the patient happier. And that person we call patient, remember, could be any of us at any time. So in effect, we are talking about ourselves and how we can make our healthcare journey a better one. HBTSS is originally a Japanese company, and our world headquarters is in Kobe, Japan. We are one of the leading manufacturers of IVD products, and we are well known in the world of hematology, as well as hemostasis, urinalysis, and other diagnostic products. But we, in the West and Central African region, with our head office in Ghana, and we are represented here in Nigeria by Uni Medicals that have offices across the country. We are focused on product lines in the first three business areas: the hematology product, the coagulation or hemostasis product, and urinalysis. And I'm going to take you through a screenshot or snapshot of these products and how we can use them for the benefit or safety of our patient. Next slide. Right, so we're talking about blood safety, blood quality, and we're talking particularly about blood transfusion services. Blood transfusion is one of the very, very common medical procedures that goes on all the time, and we are part of it. What is important is the quality of the blood that is being transfused. So as we practice transfusion medicine, we want to look at the quality of the blood that we are transfusing from one person to the other, or the blood components that are being manufactured by different manufacturing companies. By components, we are talking about the cell lines, either platelets, white cells, the plasma, or other components that could be combined from these. Now, we're saying here that there are policies and procedures in different health facilities to ensure the safety of these. However, it's important to remember that the transfusion of blood is one of the things that goes along with some risks. The risk could be transferring either communicable or contagious or non-infectious diseases from one person to the other. And that is why we are very concerned about the safety of blood. Particularly one of the procedures I'm going to talk about is the leukodepletion of blood due to the pathological associations of white cells. We can see what we call the HLA. Alloimmunization is one of the adverse effects of transfusion. We talk about non-hemolytic febrile transfusion reactions, which is one of the negative effects of blood transfusion, or cytomegalovirus transmission, which could be on monocytes in blood or could be found in plasma of the blood donor. So again, we want to look at these negative effects of doing transfusion, or even bacterial infections that could be moved from one person to another, depending on the person who is donating. So we want to look at how we can produce safe blood. And one of the things we want to measure is the leukodepletion of blood. What HBTSS is offering us is to make sure that we produce blood or blood components that are very safe. So we are concerned about not only the person receiving the blood, but as well as the person who is donating the blood. So the three triangles or components you see here, we're talking about blood component safety, the donor safety, and the patient care. Now, what is it that we're saying about the blood component safety? Again, we have procedures that are mostly manual procedures that are used to measure what we call the leukodepletion of blood, because the leukocyte present in blood could be one of the things that will lead to pathological conditions, as we have said earlier. And if you want to do this manually, it's a very time-consuming process, it's a very cumbersome process, and it's a process that requires a lot of expertise for somebody to do that at the microscope. Normal hematology systems don't give us that possibility to measure these. If you want to measure just 3 WBCs, making sure that your red cell pack is not carrying white cells, or your platelet pack is not carrying red cells or WBCs. You want to have a clean pack of RBC, you want to have a clean pack of platelets, or you want to be able to determine the residual WBCs in each of these components. We need very clean instruments that are dedicated to do this. And we also want to look at the quality of the blood that is being transfused. And that is why we have other parameters. Apart from the standard CBC and differential, we have the reticulocyte profile and the fluorescent platelet count profile that will allow us to look at the whole process of erythropoiesis that is taking place in the patient. So you see parameters like what we call the RET-HE, which is the reticulocyte hemoglobin equivalent. That is giving us clear information about the quality of the red blood cell that is being produced, and not just the count of the reticulocyte. So these instruments are instruments that provide specific modes for us to be able to clearly define the blood components, the quality of the blood component, the safety of the component, by measuring specific parameters using the blood bank mode of our XN1000 or XN2000. So the XN1000 is just one mode. If you have 2 units of them, we call that the XN2000. And they come with those optional modes that allow us not just to do a count of the cells, but to also determine the quality of our blood component that we are transfusing. Okay. Having talked about blood transfusion and the safety of the blood components or quality of the blood component that we are transfusing, one question that comes to mind is, what of malaria? Do we look at the malaria component of the blood that we transfuse? This is one issue that has come up at high-level discussions, and we are looking at safe blood transfusion in terms of being contaminated with the malaria parasite. Suppose you have a young child, or you have a pregnant woman, and you have to transfuse blood that is positive for malaria. What will you do? Will you just say that we are in a malaria endemic area, and so everybody has antibodies, so we can transfuse to anybody? It's important for us to make clear and informed decisions about the kind of product that we are transfusing. If it becomes necessary that you have to transfuse blood to a pregnant woman, to a young child, to anybody for that matter, is it important for us to know the parasite density if the person is positive for malaria? This is what is going on in other blood banks across the region. We did a study in Malawi, and now the practice in the blood bank in Malawi is that they look at blood sample that is positive for malaria, and they look at the parasite density, and blood samples that have high parasitemia are discarded. Now, to help us to be able to do this in just 1 minute, Sysmex provides the XN31. So the XN31, unlike the typical hematology analyzer, come with a different fluorescent technology using a violet laser that allows us to be able to identify parasite red blood cells because we can identify the nucleic acid of the parasite inside the red blood cell, and therefore we can count red blood cells that are infected with malaria parasite. We can give you the parasite density and the ratio of affected red blood cells so that we can see the severity of the infection. The XN31 comes with 16 diagnostic parameters, the CBC parameters, which will help us to see whether the person is anemic, which is one of the effects of malaria, or you can also look at the platelet indices, because as part of the pathophysiology of malaria infection, one of the things that we see is thrombocytopenia. So we also see along platelet indices. But more importantly, this analyzer is able to give us the different developmental stages of the parasite, and importantly, the gametocyte, which are important for transmission. And we can see that in the next slide. Right. So this is a description of the scattergram that shows the different developmental stages of the parasite. So what you are seeing, are they the ring forms? How many parasites are inside the red blood cell? Is it just one parasite? Is it more than one parasite? Are you seeing the tryphozoite stage or the schizoid or the gametocyte stages? Which is very, very key in making sure that we have zero malaria. So we need such diagnostic instruments that can give you results in just 1 minute to be able to provide these 16 diagnostic parameters, and you can clearly tell the parasite density as well as the different developmental stages of the parasite in the infected person. So let's think about what we're going to do about malaria in blood transfusion. Now we come to another important component that has to do with hemostasis. One of the things that we practice as scientists in medicine is we're looking at bleeding and clotting disorders which are resulting from abnormalities of proteins that are responsible for blood clot formation. And I say here that hemostasis is basically about keeping that balance between clot formation and clot breakdown. And you can see from the other end how that balance has been tilted in favor of clot formation. Now, what we need to keep in mind now is there are different clinical conditions that can tilt this balance. Even something as normal as pregnancy. A healthy pregnant woman is at risk of blood clot formation. Who tests for that? Who screens them for that? So we have pregnant women who have so much clot form, and in the end, they may end up with other pathological conditions. Sickle cell disease, which is one of the common conditions that we have, is one of the things that can tilt this balance in favor of clot formation, because there's always chronic activation of platelets that leads to blood clot formation. And the person may die not only from the disease, but the activation of clot formation that is taking place inside the patient. So we need to be thinking about what condition could tilt this balance either in favor of clot formation or bleeding. And somebody could have what we call pathological clot formation. Yes, as you can see there, pathological thrombosis is that which has blocked the whole vessel, that no blood is being transferred or no blood is flowing through the vessel. Unlike what we see here as normal physiological clot formation, where blood still flows through the vessel has been healed, the clot is formed, and it goes through the process of the fibrinolysis to break down that clot and restore normal blood flow, and macrophages will pick up those pieces. So in physiological blood clot formation, it's a reversible process, unlike the other pathological process which is not reversible. Now we want to have diagnostic systems that will be able to help us to determine what is somebody's risk of having a bleeding disorder or clotting disorder. And that leads us to, next slide. Very simple equipment. We call these the CA101 or the CA104. These are equipment that use the technology of clot formation. Okay, so they are using clot formation process to be able to give us the result. So you can measure your prothrombin time, you can measure your APTT, you can measure your thrombin time, you can measure your fibrinogen, you can measure your clot coagulation factors as well on either the CA101 or the CA104. Now, they are semi-automated. But if you have high volumes and yet you don't have the request for advanced testing, you want to automate the process, then you can go in for the CA620, which is still using the same coagulation method for like the semi-automated, but it is an automated process because you have high volume. You just want to load the samples and walk away, and the system will do the pipetting and give you a result. So the CS620 is a fully automated form of both the 101 and the 104 that could be used in high volume places. Where we are interested in more specialized tests, then we could move on to other advanced tests that I will talk about later beyond doing the PT and the APTT. But just to draw our attention to something, I'm going to use this case as an example. Look at this case very well, and you can see this patient has a normal prothrombin time result, right? You also see another patient here, the second result for APTT with 32 seconds is also within the normal range here. So clearly, we can see that this patient who has what problem? Total hip replacement, yeah, and he has a significant bleeding history. But when you run the PT and the APTT, it's normal. So you may be asking, why would somebody with such a history, significant bleeding history, and of course has gone through his bleeding? What is the reason behind the bleeding? Now, if you look at the result for the von Willebrand factor antigen and then the activity, we can see that they are low. And this is pointing to what we call a quantitative disorder of the von Willebrand factor. And that is the type 1 von Willebrand disease, which is quite common. All right? So what we want to see here is that measuring PT and APTT are only assessing what is happening at the what? Secondary phase of hemostasis and not the primary phase of hemostasis. So if you have a disorder in the primary phase of hemostasis, you have a misleading normal PT and APTT results. And this gives us more reasons why we need to look beyond doing the normal routine test. A second case I'd like to show you briefly is another patient who shows normal PT and normal APTT results, but shows very low factor 13. Now, factor 13 deficiency is another reason why somebody will experience bleeding. All right, but factor 13 is not assessed by PT and APTT testing because it occurs at the end of the whole fibrinolysis process when you have converted fibrinogen to fibrin, and you now need to stabilize the fibrin mesh that has been formed into a blood clot. That's why you find factor 13. And so in factor 13 deficiency, you are not able to form a very firm solid clot. And that's why you see blood clots that are loosely formed and the person is still bleeding, right? So that gives us reason why we should go beyond doing the routine clotting test. So assessments provide you with a wider range of hemostasis analyzers beyond just using the clot formation technology. We have analyzers that are based on chromogenic assays, okay, for immunologic assays, and even for platelet function assessment. So we have the CS660, we have the CS1600, and now, keep clicking, we have up to the CN3000 and the CN6000, which are more advanced hemostasis analyzers that have more advanced methods for detecting hemostatic disorders in any patient. Yeah. Then in the hematology range, we have our 3-part differential analyzers. This is the recent one we call the SQ320, which is a 20-parameter 3-part differential analyzer. Right. But the point is, we see patients that don't always present with normal cells. Patients come with immature cells in peripheral blood. Patients come with what? Abnormal cells in peripheral blood, which cannot be detected at the level of 3-part differential analyzers. And that is why I say we need to know more. We need to decide with confidence, and we need to act faster. For us to be able to do this, we need more advanced technology that will help us not only to see normal cells in peripheral blood, but to be able to identify the abnormal cells and even the immature cells that come into peripheral circulation to give us indication. For example, if you're looking for nucleated red blood cells, if you're looking at immature granulocytes, which are very good indicators of adverse condition in any patient. If you're looking at immature platelets. So we have more advanced analyzers, and this is the low-end 5-part differential instrument, ranging from the 330 to the XN550. They are the low-end 5-part differential instruments. Beyond this, we have the more advanced, we call the high-end 5-part, and they include the XN1000 up to the XN9000. And these come along with total hematology. When I say total hematology, I'm talking about moving from cell count to cell morphology. So the analyzer is doing the counting of the cell, is preparing a blood smear for you, it is screening the blood smear, it is giving you digital imaging of all the cell populations that you have. Even if there are abnormalities, you are able to see them. These come with the most advanced high-end 5-part differential analyzers which are possible. Now, I know we are talking hematology here, but it's also important to know that hematology is closely related to urinalysis. Why? Because the same, and so it's important to look at some abnormalities that could reflect in urinalysis as a result of a burden on the kidney. We're looking at chronic kidney disease, which is one of the major conditions that we see all the time. And we have a lot of risk factors, such as what? People with diabetes. We see them every day at the clinic, right? Yes. People with what? Hypertension. People who are obese, cardiovascular condition, smokers, aging, or even people who are genetically predisposed to such conditions. Look at the burden of chronic kidney disease. By the year 2030, we're looking at 5.4 million people being on dialysis. And look at how dialysis cost increases from one stage to the other. So what we want to keep in mind is that we should be able to what? Help in managing these patients by performing the right clinical tests. So HBsn provides the solution. These are very good diagnostic systems using your urine chemistry analysis to be able to provide not only the routine parameters that we know, but we can also see parameters like proteinuria. So when you have high protein in urine, or microalbumin, what we call albuminuria as well. These are very good indicators of somebody who is likely to have a chronic kidney disease. Whilst your estimated glomerular filtration rate may be giving you normal result, that person may be having a problem. And by the time you realize it, there's so much of structural damage to the kidney that there's nothing that can be done. So these are early indicators. Measuring your microalbumin and your proteinuria are early indicators of someone who will end up with a renal failure. So we want to use these basic principles with our UC 1000 and UC 3500, which are chemistry analyzers. Next one. And as well, focus on infections in the urinary tract and what we are all concerned with now, the antimicrobial resistant issue. Again, we see people who are at risk. Females, by virtue of your sex, you are one of the groups of people at risk for UTI. It's not anybody's fault. It was your choice to be a female. Diabetic people, okay? People who enjoy multiple sex partners, obese people, genetic condition, chronic conditions like HIV, of course, poor hygiene. These are all risk factors that expose people to these conditions. And we want to go fighting this. And that is why we say our aim is to reduce the workload in the lab, to reduce the excess cultures that are made. There are a lot of unnecessary blood cultures that are done, or urine cultures that are done. How do we eliminate this? We should be able to determine on the first day that a patient comes to the lab that the person has bacterial infection or not. And within 1 minute, you can do this with the next model of analyzer that HBsn provides. And That is our UF1500. The UF1500 comes with 17 diagnostic parameters, including bacteria count. So you don't need to do culture before you find that the person has bacteria. And you will have a scattergram. The scattergram will give you an indication of whether it is what? A gram-positive bacteria or a gram-negative bacteria. So that at least on the very first day, the clinician can take a decision on what therapy to give. So the UF1005 is helping us fight unnecessary cultures, excessive cultures, reducing your workload. And you do a lot of cultures only to find the next day and write no bacteria growth. We don't have to wait for 24 hours to write no bacteria growth. No. All right? So UF1005 comes with a solution for that. And even give us parameters that can give indication of somebody who has a bladder cancer. So this is where we want to go for our diagnosis. With that,
this conference is what? Conferencing. Hello? This conference is what? Conferencing. This is very impactful. Thank you so much, 6MEX, for this wonderful presentation. He actually took us from where hematology, we went to where parasitology, he took us back to chemistry and brought us back to hematology. Another round of applause for him. Thank you very much. And you can hear how he was pronouncing things. He will know he's actually coming from Ghana. So please manage our own in Nigeria. Thank you very much. There's an announcement.
I can see that we are all enjoying ourselves today while the session is going on. For the first phase of the sections for today, we just finished with the product presentation, and I hope you all enjoyed the product presentation. So while you're aspiring to be a very strong medical laboratory scientist, please do well to patronize these people and see how you will have a strong and reliable medical laboratory center to serve the society better and best. Hello? I have just been reliably informed that if I don't make this announcement again, our payment will not be complete. I've been asked to tell you that we have limited copies of these. So please do well during the tea break to get your copy, and it makes your conference complete. And again, I have been asked to plead with us that if there is any vacant seat in front of you, people are watching this conference live. This is an international conference. So just occupy the empty seats before you, so the picture quality and the video quality of what we are doing, people would appreciate it. As you do that, God will bless you. Don't forget, there is 50,000 naira to be won. Thank you.
Thank you very much. Okay, let me add to our Ghanaian speaker. Please, for those of us that are doing blood transfusion, you will bring them down to parasitology department for us to run what? Malaria parasite test on them, right? Before they can donate. Abi, please, that should be done. Then our next speaker for this scientific presentation is a director of medical laboratory service. She's a director from LAUTECH, all the way from Obomosho in the West. Let's appreciate Mrs. Zakiria Tawa Kalitu. You're welcome, ma. Tawa Kalitu, you're welcome, ma. She's to take us on transfusion and hemostasis, monitoring of anticoagulant therapy. Thank you, ma.
I would have advised you to give the mic to our president to pronounce my name next time. Okay. You know how to pronounce this very well. Thank you very much. Good morning, my elders, my teachers, my mentors, my students. Permit me to stand on the existing protocol because of want of time. Why now? That's not my...
Is this not you?
No, anticoagulant monitoring. This is Karim.
What is your... You sent to me on WhatsApp.
I gave you yesterday now.
Yesterday. Check here. Which one is it? This one.
This one. Thank you very much. Once again, I say good morning to everyone, and I want to appreciate the Hematology and Blood Transfusion Society of Nigeria for putting up this program so that we cross-fertilize ideas, we learn new things, and improve in our service delivery. This morning, we are going to talk about monitoring of anticoagulant therapy. As we all know, anticoagulant therapy will be done on the ward by the clinicians, but we are the one to monitor it, whether the dosage is in line, is it in good quantity, are they to reduce it so that the patient will not face the risk of hemorrhage. So, these are the workshop objectives. Upon the completion of this module, participants will be able to understand the anticoagulant therapy, various types of anticoagulant medications, indication for anticoagulant therapy, effect of anticoagulant medication, and monitoring of anticoagulants. Next slide. What's wrong with your... The anticoagulant therapy refers to medications or treatments used to prevent blood clot from forming intravascularly, or to keep the already formed clot in its size so that the clot will not go bigger again. That is the objective of anticoagulant therapy. And the mode of action is that the anticoagulants will reduce the body's ability to produce the clot by blocking some enzymes which are responsible for clotting formation. Then anticoagulants are commonly prescribed for individuals at risk of clots in medical conditions like 1. Arterial fibrillation, that is formation of fibrin in the arteries. Then deep vein thrombosis, mechanical valve device. We have some patients who their cardiac valves are no more working well. So in this case, they will implant mechanical device inside their heart so that the valve will continue to serve in place of the original valve. And once this valve is implanted in their heart, they will continue to be on anticoagulant therapy for life. And for patients with history of stroke. Then periodic check of antifactor 10 acid level. This is the result that helps to guide a low molecular weight heparin dosing counts. This is very, very important too. We all know that in any patient that is having thrombocytopenia, they are at risk of bleeding. Then we can equally use vital signs and symptoms to monitor this anticoagulant therapy. A patient may have like 4 or 5 tests to be carried out. So we should let our technicians, whoever is handling the phlebotomy section, to know the order of blood, draw of blood, so that we have the blood culture bottle, order 1. Secondly, We have the citrate bottle, plain bottle. Then the yellow one is plain bottle too, but it has cloth retractor inside it. Then that is little heparin, followed by EDTA bottle. EDTA is number 6. And lastly by fluoride oxalate bottle. So those ones that have enzyme, what is it? Something that can destroy enzyme, they will be collected last. That is the essence of the order of the blood. Then instrumentation for blood coagulation test. We have 2 basic methods for this test. That is electromechanical method, the one we do in our lab. It's not affected by turbid samples. If you have turbid sample, we can confidently use this method. Then it provides a cutting time determination for coagulation testing, and it is less expensive compared to automation and reagent. And because of the turbidity of the sample, the light will scatter, and limited light will landed on the detector, and the thing will be read as your OD. Then, like I said, I talked about platelets before. We use our complete blood count to get our platelets, either manual or by automation. And we all know that the normal range for the platelet count is 150,000 to 450 per microliter, which I encourage all of us as med lab scientists. We have talked about it in one of our conferences, that we should have a normal range for our vicinity. It's very, very important. All these reference values are for Caucasians, so we should be able to develop our own normal range too. So when there's thrombocytosis, the platelets will be about the upper range of the upper limit of the range, and the thrombocythemia too. Then the prothrombin time and INR, like I said before, this is one of the tests that is used to monitor warfarin. And the reagent comes with PT reagent, in which the calcium is already incorporated in it, and it monitors the extrinsic pathway of clotting system. So after generating our PT, we calculate our ratio, that is PT of plasma over PT of control. And our INR now will be generated from ratio, that is PT ratio raised to power ISI. And the ISI is International Sensitivity Index, which comes with each batch of reagent. When you open the carton of this reagent, you will see a leaflet there. So there is ISI already written for us on the table. So you just juxtapose your result, your test result, and you get the final result. And we have the PT reference rate, 11 to 13.5 seconds. INR reference range. Now, for somebody not receiving anticoagulant, the INR should be 1. If somebody is not receiving anticoagulant, but somebody on anticoagulant, the reference range is 2 to 3 for patients on anticoagulants. Next slide. Then the APTT test. This one composed, the reagent of APTT is composed of soybean phospholipids, that is partial thromboplastin, and the particulate activator like kaolin, ellagic acid, silica, and cellulite. The activator initiates the contact system, then the remaining steps of intrinsic pathway take place in the presence of phospholipids. APTT arrives at immediately at the first appearance of fibrin clot, and the time is taken. And the reference rate is 24 to 35 seconds. Then the another test I've talked about that we can use to monitor the anticoagulant therapy is assay for anti-factor 10, anti-activated factor 10. And these reagents contain chromogen substrate, which is required for the process, the procedure. And it's the only functional assay that deal with the exact system you are looking for. Like the other PT and APTT, they monitor the whole intrinsic or extrinsic pathway, but this one is highly specific. So a no amount of activated factor 8 will be added to platelet poor plasma. That's the one we get from our patient, and chromogen will be added, and at the end of the day we read our result photometrically. The reference rate for activated factor A assay is patient not receiving anticoagulant therapy, their value should be 0 to 0.1 micro per mil, IU per mil. Then patient receiving direct oral anticoagulant, we have pre-dosage level. This is very, very important. Before they start anticoagulant therapy, they must know the status of that patient before proceeding to the therapy. So pre-dosage level should be within 0.1 to 0.5 IU per mil. Then peak at 2 hours post-dose. They will collect another sample and we must test them. The normal value should be 0.5 to 2.0 IU. If it is more than 2, that means the patient is at risk of hemorrhage. And this is the procedure for the anti-activated factor 10 assay. That's the sample which contains heparin and antithromboin. When the reagent is added, that one will aid the reaction between the two substances at the tube 1 and the chromogen, that is the star. When added, we have this. The excess chromogen that was unable to attract, that is what we are assaying for. That is what we are going to read at the end of the procedure. Then this test is highly specific assay, like I said before, which tests only the in vitro functional status of heparin, not the entire coagulation system. And as good as it is, it has some limitations. So absorbent interference, like when you have sample, like jaundice sample with high content of lipid, it is not good for this procedure. A grossly lipidemic sample can be subjected to increased centrifugation, while sample with significantly elevated bilirubin should be tested by APTT. And this is protein reagent from HBsn. Yes. And this is for PTTK. HBsn. Go back. And this is for anti-factor, activated factor 8 assay reagent. The one in brown bottle is the chromogen, and we all know why. Because chromogen are photolabile, so they must be kept in colored bottle. Then as a main lab scientist, we must know source of error so that we'll be able to guide against these errors while we are working. First, well, we have pre-analytical error. These are the errors that occur before the commencement of testing of our sample. Prolonged venous stasis. If perchance the phlebotomy is not getting the vein on time, this can affect our results at the end of the day. Difficult phlebotomy, which can cause hemolysis of the sample. Use of narrow gauge needle. As we all know, we have different type of needle, but for the sake of this test, we must use 21 downward, 21G downward. 21G is the one with green color. Then, late dispensing of sample into bottle. We all sometimes we fall into this error. In an attempt to locate vein, maybe the thing is not coming out very well. We were searching. I want to remind us that immediately a drop of blood entered the syringe, the clotting cascade has begun. Do you understand? So if you fail to dispense that blood early enough into bottle, no amount of anticoagulant can challenge the calcium again, because once the clotting cascade begins and it has reached the calcium level, do you understand? So if that stage has reached, before you drop the bottle, dispense the bottle into the sample into the bottle, definitely the blood will clot. And that was always happen when they collect sample from ward. They will tell you, after all, I just dispense the sample into bottle now, it's not clot. But they don't know that the clotting system is already initiated. Then, improper mixing of blood. We all know that. Incorrect blood anticoagulant ratio. Yes, this is one of the error. And in my facility, when we experienced this kind of problem, what we did is that we took the bottle and put a mark on the bottle that this is where the blood must reach. So if they are collecting below the mark, we reject. If you are collecting above the mark, we reject. So immediately we are issuing the blood bottle to perform bearer. We tell them, tell the doctor the blood must be at this level. So by the time they come back and it doesn't match our instruction, the patient will be the one to be siding us. Hey, after all, I told the doctor. So that's what we experience, especially when we have new house officers. Then, use of stain sample. Yes, sometimes they may come to lab, they want to collect sample. The sample will be collected the following morning. They will not collect the bottle. But unfortunately, the house officer comes maybe around 10 p.m. Before the day they wanted to collect the sample. The house officer will just collect the sample and they will keep it somewhere. So, following morning, they will not bring it to you, to the lab. Okay, they have collected the sample. You will be working with stain sample. So, you don't pre-issue bottle when they are not yet ready to collect the sample. Then, combining blood sample from different tubes. We had an experience on this too during the Lassa fever period. That doctor just came. We have a patient so name. He brought one sample. Can we have the sample? He went to Campus 2. He went to Micro 2. So I was wondering. So I had to call him and sit him down. Sir, what do you want to use the sample for? That sample is our property. When the sample enter this place, it's our property in the laboratory. Now he now told me in confidence that they later find out that woman may be suffering from Lassa fever. So they want to use those samples to go and do the whatever test they want to do. You now combine EDTA sample with sodium citrate, with heparin. You want to combine the sample so that it will match the volume of sample they will need for PCR test to determine whether the patient is positive or not. And I told him, those you know, those bottles contains different anticoagulants. So we sat down and educated him on this. The improper labeling of sample. Yes. Analytical error, use of inappropriate volume, inadequate testing temperature. This is very, very important too, because like I showed you before. Then contaminated coagulation test tube. Yes, anybody on coagulation bench, there is a sacrifice we must make. Please always wash your test tube by yourself. Most of the time, the attendants in the laboratory, they don't wash it very well. So we just get a day that you just add sample into those tubes and everything has clotted, even before you had the reagent. So endeavor to be washing that tube yourself and keeping it so that you won't get to a bad situation when those tubes are not well washed. Then poor illumination. For us to identify the clots immediately the thing form, we must provide overhead lamp if we are using manual method. Then error of paralysis. Some people may not be able to recognize the clots very well. Then by the time the thing clots, you won't be able to take your time immediately. Use of 40 timer. Inadequate centrifugation of sample. This is very, very important. We must have our platelet poor plasma. And how to get that is that you centrifuge your sample at 4,000 revolutions per minute for 15 minutes before you test your sample. The use of expired reagents can be a source of error too. Yes. Next slide. Then we have analytical error, poor calculation. Yes, like when we are testing, we normally put it in a rough sheet before we do the final calculation. So if care is not taken, we will fall into transcriptional error too. The failure to follow manufacturer's instruction is part of source of error. Conclusion. Anticoagulants have a narrow therapeutic range, meaning that there is a small window between the effective dose and dose that can cause excessive bleeding. Monitoring helps ensure that the patient's anticoagulant levels are within the desired therapeutic range, reducing the risk of potential complications. Maintenance of good laboratory practices is key in proper monitoring of anticoagulant therapy. Thank you very much.
Ladies and gentlemen, once again, put your hands together for this beautiful presentation. It will interest you to know that based on my own perspective as the anchor of this program, there is a take-home for me. And the take-home for me is having in mind what we call patient relative. I have learned another one that it is what? Form bearer. So the person that comes to the lab may not be a relative to the patient. It could be a volunteer. So I have learned another one. So the money I paid for this conference, they have not given me the kind of food I want. But I have learned what I have not known before. Please put your hands together for myself and my colleague. Now, I don't want to be selfish. Also put your hands together for yourself. After that, let's take one question each for product presentation, 2 questions for this presentation. So we can go for our tea break. 1 question each for product presentation and 2 questions for this presentation. Okay.
Mr. President, all protocols do that. Mine is not really a question, but looking at the call by the presenter from DCL asking or saying that a lot of laboratories are currently owned by doctors. That is a fact. The question now is, how do we surmount that scenario? Because as laboratory scientists, we are disadvantaged because we don't control the patient. The doctors control the patient. And then in terms of funding, most of them can access funds. So they have the capacity to actually buy most of these equipments in their facility, and then they will employ, if they want to be generous, they employ the lab scientists to work with them. If they want to be mischievous, they employ the SLT to work with them, because technology has simplified the whole process. So you just do a hands-on training, you put this into this, and you get that. But I think it's beyond that. Because when something goes wrong, that SLT, that quack you are using to operate that system, will not be able to detect when something goes wrong. If you look at the precautionary measures mentioned by our last presenter, it tells you that you must have requisite knowledge in what you are doing to be able to generate a standard result. Cost of these equipments are very expensive. So our call is to the vendors. How do you encourage the laboratory scientist who is not well disposed in terms of finance to have this? Number two, you can have fantastic equipment, and then the doctor who says he's the owner of the patient is directing or controlling the patient to a particular spot he's interested in, not to your facility. So we have challenges both ways. But I think there can be a meeting point where vendors will be able to come up with a strategy to allow us own these facilities, so that, because we are better positioned to use these equipments and advocate their importance on their behalf, not the doctors. But because of their advantage position, they have that edge. I take a case study. In the era of COVID, most of the facilities were owned by the doctors because they could access funds. It only took few of us to summon courage to be able to surmount that. And I think Soji, myself, and co, we had molecular lab. You know how expensive it was to have that. So the bottom line is, the lab scientists are better positioned, but there must be a strategy to encourage them. One of them could be cooperative, joining forces together to be able to acquire these facilities, machines, and then use them. Another call will be to government to help, because these equipment are foreign exchange based. They are expensive. So government should come out with a policy to help the laboratory assess these equipments at a subsidized rate. HbTSSN is doing something. They have set up a cooperative, asking members to join. With that kind of cooperative, we can actually access funds that will help us acquire these equipments and then advocate for quality results. Thank you very much.
That was a very wonderful contribution from my own senior brother, a senior colleague I look up to. Sometimes I just travel to Delta States to understudy his ways of practice, so I can be like him. Please, once again, put your hands together for that beautiful contribution. Do we have another question? Okay.
Yeah. Based on the issue he raised, even though he has proffered a solution that we can form cooperatives. But it's important that we allow these companies to talk to us on the way forward, how they can help medical lab scientists who are not favorably disposed in terms of funds to acquire these equipments. So this year and 6 months, we want to invite you to address us. Thank you.
Thank you, ma'am. Okay, so during my presentation, I mentioned that we can partner with whoever that wants to open a lab. We can partner with you. We can design the plan with you. In terms of funding, yes, it's a challenge because so many funds are valuable, will be needed for it. If you check, there are so many laboratories everywhere. You see almost all the streets. In all the streets, you see labs. But those labs are not what you can call a lab. And some of them are owned by scientists. Majority of them, actually. But the ones that are making waves are the ones owned by doctors. It doesn't mean that we are not working hard, but planning is important. Not when you have little fund, you say, oh, let me go and buy a microscope, let me go and buy this and start running a lab. It's not done that way. You engage professionals, you engage the vendors, let them plan with you the right equipment, even when the funds are not there. There are so many ways to go about it. You understand? So we can even help you to access loan. We can even also give you this equipment and give you payment plan. This, if you don't have the fund, okay, you can pay installments and give you a timeline to complete the payment. We can also do placements, place the equipment, then as you are buying the reagents, you are paying gradually. So you must not have millions of naira to run a lab, but you need the understanding. You need to know the right persons to meet. There are so many vendors, there are so many persons selling equipment. Some of them, you will call them, I need this equipment, they will tell you, okay, but you have to pay money. This is the money that you need to pay and all that. So in all these things, you need to have the right information. Who are you meeting? Meet the right persons that, like for us in DCL, we are known for laboratory instruments, equipment servicing and all that. So when you come to DCL, we will plan with you. You tell us, okay, this is what you want, and this is your budget, this is the fund available, but this is the standard I want. I must not go below this standard. DCL will come and say, okay, since this is the fund available, look at the options that we have for you. That will be favorable to you and also be favorable to DCL. It will be a win-win situation because these analyzers, when they are in our store, we are not making anything from it. So it has to be, all of them have to be in use. So how do we use it? It's us here, the scientists, that will use them. So that's why we encourage that even when you are working for government, during your retirement, you can own a lab, you can own a research lab, you can own a clinical lab for diagnostics. So even when the funds are not available, just come. We'll plan with you. It's not a problem. We'll plan. But just have a plan that, yes, this is what you want. Then we'll now take it off from there. Thank you.
Thank you very much for the question, and I will talk about what happens in our regional office. When I say the regional office of Sysmex, that's in Ghana. We have a distributor in Nigeria, that is Unimedicals, that you can also plan with. So essentially what we do is this. Once you set up a lab, you need equipment, you come to us. A number of people walk to my office and say, I need hematology analyzer. We have a plan for how to help you get analyzers. But it depends on whether you qualify for the contract, because we have to sign an agreement. And what goes into the agreement is, number one, what is your client base? You should be able to run a number of samples in a year. Once you qualify for that, we give you the analyzer on placement basis. And usually we do that for a number of years. In some areas it's 3 years. What that means is we give you an analyzer, we give you reagents. We do the installation and the training free of charge. Then the reagents are for 1 quarter. So for the first quarter, you use the reagent, then you pay for the reagents you have used. Once you've made a payment, you get reagent for the next quarter. And this goes on for 3 years, after which you are able to finish paying for the analyzer, and it becomes your property. During that period, the servicing of the analyzer is done free of charge by Sysmex. So this is one plan that we have. That is the placement procedure, based on your ability to meet the number of samples we require. The second one is to have outright payment, if you like. So if you have money, come to us and say, I have all the money. Take and give me the analyzer. It becomes yours. Decide how much reagent you want to buy anytime you want to buy. That's fine. Then in that case, you get 1 year of free service, after which you sign a service contract and your analyzer will be serviced periodically. Even with that, depending on the number of samples you are able to turn up every year, you can qualify for free service. We have that arrangement also. The other arrangement is for you to pay in part. So you come to us and say, okay, I can pay 1/3 of the amount for the instrument, and the rest can be spread. That can go into an agreement with, depending on which distributor you are dealing with, or with our head office. So these 3 modalities are there, and you can benefit from them. It doesn't matter whether you are a clinician or you are a medical lab scientist. What we need to see, we want to see your facility, see that yes, you have the potential to generate the fund and make payment. Then we agree on that. So these are possible models. Thank you.
I hope the response from both company has given us a direction and headway towards achieving establishment of medical laboratory, service. I could remember when a young graduate came to me and asked that his father was to sponsor him for a very equipped lab, and I gave him some advice, and not long his father decided he goes to further his studies and come back before that can be done. So partnership is also, possible. It will work someday. Okay.
Last one.
Good morning, our president and everyone present here. Okay, I want to ask the recent and past presenters, in acquiring equipment for lab, isn't it possible to have you place your equipment in the lab and then have the scientists pay for the reagents? I've seen that happen in a lot of laboratories. You don't have to buy the equipment, but we buy your reagent, and because we can't possibly use the equipment without using your reagents. Is it possible? Thank you.
Yeah, DCL, can we have you please respond to her?
Okay, it's possible, but you have to qualify for that. You can't just see a lab and say, oh, come and take equipment and buy reagents. There are some pre-qualification that we do. So we need to check what's your sample volume. how many samples do you run per day? If you are running, for example, if you are running 1 or 2 samples per day, and you say you want to have 5-part analyzer, that we should come and place 5-part analyzer, you know it won't be possible. Because we agree that that person is going to buy a certain number of reagents, either quarterly or monthly. So if we agree that, okay, you are to buy 1 set of reagents, for example, for hematology analyzer monthly, what happens if you are not able to use the whole reagent? Because you will be under obligation to buy again. Meanwhile, you are not using it. So the first thing is to know if your center is qualified. When you invite us, we will come and check. Okay, how many samples, you give us all the data, what you do in your center, we'll check how many samples you run and all that. If you are qualified, we'll give you analyzer, we'll place it and tell you for certain number of time or certain, for maybe 3 years or 5 years, you will buy reagent from us. Once that 5 years or 3 years expires, the instrument becomes yours. You can buy reagents at any time you want to buy. You are not under any obligation to buy 1 set, 2 sets, or even 3 sets of reagent. So it's possible, but it all boils down to their sample volume. We can place instruments. If you have a lab and your volume, you have the volume, we can place instruments for you. Then you buy only reagents. You don't need to pay for the instruments. It's possible. Thank you.
Okay, I have received a very strong signal that we have to take break from here. But then it is important to know that this program or this conference is being transmitted live. Go to Solve TV NG, go to your YouTube, you will watch this live. Send it to your friends that are not here, your colleagues that are not in Yenegua, wherever they are, let them just go to YouTube and they will watch this program live. The society made it this way so you can watch from the comfort of your corner. Thank you very much. For the tea break, please allow our senior colleagues. When you look at yourself, you will just know that this person is my senior. Let the person assess the tea break while the person is coming. Then you will go look at yourself. Oh, we don't know, but look at yourself. Be truthful. You know, there is a question from the Bible that will earn us 50,000. If you look at yourself and follow this instruction, I tell you, you might be the person that will win that 50,000 naira. So our seniors, please. Me, I know myself. I'm in middle. I'm not junior. I'm not senior. I'm just in the middle. So thank you very much. The tea break is ready. I repeat again, look at yourself and know when you should go to that place. Thank you very much. So immediately after the tea break, we'll go into the next presentation. If you will forget everything, don't forget, look at yourself.
Bring down the seats for the scientific session 4.
Okay.
They will get
Dr. Benjamin Eledo is one man that has hemostasis quite right on his fingertips. If you look at his face, you will see everything, the extrinsic and the intrinsic pathway. If you look at the way he swings his hand while walking, you will know that his calcium cannot be deficient. Once again, put your hands together for Dr. Benjamin Eledo. You're welcome, sir. Ladies and gentlemen, like I said earlier, another important on the list of the panelists, it's one man that I said I usually just travel to Delta State just to learn his ways and come back because of our profession. It's one man I love so much. When he called me, or when I called him, sir, because of the love I have for you, I want us to do a publication together from University of Delta in Agbo. And she happens to be my classmate. Mina, right? Yes, I'm correct. So his family is a family of medical laboratory scientists. Hello. Mr. Collins is one man, if you meet him in all AMSIN conference, you will be glad you came to that conference. Ladies and gentlemen, once again, put your hands together for him. My teacher, whom I considered a mother, only that my lawyer is wasting time to bring all my adoption certificates. She taught me, and each time I'm traveling from Bayelsa to Port Harcourt to take lectures, in my mind I will say, if I enter this class late, I wouldn't want my teacher to notice that I came late. So I even arrived class before the people in Port Harcourt. This is no other person than Dr. Mrs. Evelyn Eze, all the way from River State University. I was so happy, super happy, and I was filled with torrential joy when during my final defense in my MSc, I looked at the name I saw on my screen. The person to examine me happens to be Dr. Mrs. Evelyn Eze. I said, when you have someone on the mango tree, you cannot eat unripe mango. So I already knew the next thing will be success, and it came to pass. Once again, put your hands together for her. Once again, this session will be moderated by Professor Mrs. Nancy Ibe, and it's on hemostasis and medical laboratory practice. Distinguished guests, ladies and gentlemen, permit me to leave you in the hands of my mentors. Thank you.
All right, thank you so much. And we are looking at this topic. Said. Hemostasis and transfusion science, right? And medical laboratory practice. Hemostasis and medical laboratory practice. So I have here erudite scholars who will do justice to the topics. We will bring up topics or questions, we generate questions, and
we have ADP, then we have serotonin. The function of ADP is to attract more platelets to the site of injury. Serotonin is a vasoconstrictor, and thromboxane A2 helps in degranulation. So in all of this, the essence of this is to form a platelet plug and to stop bleeding. The third mechanism is the coagulation cascade. All of us know the extrinsic and the intrinsic coagulation cascade. And in all this, it ends in, you talk about the common pathway where the intrinsic and the extrinsic pathway meet, leading to the formation of a stable fibrin clot and the stabilization of the clot by factor 30. When this happens, the fibrinolytic pathway must be activated to make sure that the clot is being digested. And it starts by the protein we call plasminogen, that is converted to plasmin that comes to digest this clot. And all of us know that if this mechanism fails and the clot detaches and enters into the brain, you know what will happen? If it enters into the heart, it causes cardiac arrest. If it enters into the lungs, it will lead to pulmonary embolism. Now let's go to the question, how does a med lab scientist contribute to burns? You know that when there is a burn injury, fluid is being lost and there is high increase in PAC cell volume because there is trauma and many fluid is lost. So how does a medical lab scientist contribute? In the hematology department and in the blood bank, we do complete blood count. And when you do complete blood count, one of the things you have to look out for, one, when there is inflammation, or when there is a disease, or when the bone is infected, you will have a high WBC count. Also, there will be dehydration leading to high PAC cell volume, and the red blood cell count will be low. It is the medical lab scientist that is expected to carry out these investigations. Above all, it is our duty to provide the fluid to replace or hydrate the person that is suffering from burns. The best fluid is albumin. You can use albumin, or if you have fresh frozen plasma, you can make this available. Thank God the Federal Medical Center Yenegoa has a system that can make this available. Thank you very much.
Thank you so much, Dr. Ben. You see, yesterday we were able to know that med lab scientists are also involved in manufacturing, not just diagnostics. You see, what makes hematology and blood transfusion science tick is that we are a tripartite department. We manufacture blood products. It's also a visual art because we use our skills to look at the morphology of cells. It's an art. None other department within the medical laboratory does. We look at these cells and be able to look at their quality, morphology, and then again, we now do what other med lab scientists does, analytical process. So you see, for what he had done, what Dr. Elodo had said, that we can prepare fresh, very valuable in managing burns, because what they need is rehydration. Entertain further contributions as regards that question.
Thank you, my moderator, and good afternoon, everybody. I want to add a few things to what my panelist has just said. He has been able to give us an overview of the physiological process known as hemostasis. I want us to know that if there is distortion in this normal physiological process, that it will get into pathological scenario, which can either be excessive bleeding or clot formation, abnormal clot formation, what we call thrombosis. And the role of medical lab scientists is enormous in trying to manage a patient who has burns. And of course, we know that the there are different degrees of burns, and that will mean that the manifestations will vary in terms of degree, and the therapeutic approach also will vary in terms of degree of burns. He has stated that we need to do the complete blood count, yes, but the med lab scientist does not just stop at the diagnosis, carrying out those tests. Aside carrying out the complete blood count, which will help you to know whether the patient is anemic or whether he's having excess red blood cells emanating from dehydration. As a med lab scientist also, we are part of those that monitor the progress of the clinician's treatment. And of course, we do also that through some analysis and even through research. The research we do in our various, for those of us in academia, the research we do will equally go a long way in improving patient outcome as relates to burns. But beyond the CBC and beyond knowing the total white blood cell count, of course, we know that burn patients, that their first protective barrier is being tampered with. So the skin is what shields us from infection. That's the first protective barrier. But when somebody sustains burns, depending on the level, the degree of the burn, this protective barrier is tampered with. And how do you know? How do you know whether, as a result of this exposure, the patient is infected? It is we, the lab scientists, that will take a sample or swab the area and do microbial analysis. So we do microbial analysis, and when we do that, we'll be able to know precisely the type of bacteria or any other pathogen that is that person that has infected that person. And because of that, the clinician will actually, of course, when we will do our culture, we know what next to do, and then we'll be able to come up with the best antibiotics to be given to the patient, and that will help in improving the outcome. And when all these steps have been released to the clinicians and the patient is being monitored, we equally do them, and it will also help the clinicians to know, is this patient's condition deteriorating or is it improving? Should I change the treatment regimen? Should I make it more aggressive? It will be able to, the clinician will be able to know from what we have given the clinician. So we have a whole lot to do when, as regards burns, patient in management and in diagnosis and in every other aspect of clinical service. Thank you.
All right, I would just want to add a little voice to that, because from the contribution so far, you can see that the role of the medical laboratory scientist in managing burn patients are enormous, and a range of activities have been presented by the speakers. I would just want to add that one of the critical areas we look at in cases of burns is loss of fluid. So when fluid is seriously lost, depending on the degree of the burns, the role of the lab scientist is to do the electrolyte analysis for that particular patient in terms of monitoring the progress of how it's going. Then a little further, Madam mentioned the issue of the skin, which is the first site of burns. Now, there is emerging tissue engineering that is on. And tissue engineering encompasses the medical laboratory scientists, the engineering sections, coming together with the various principles behind them to generate tissue that can be used for the purpose of transplant. So beyond our investigation on the bench, we could collaborate with the engineering unit to actually generate tissues. Thank you very much.
Thank you, thank you, thank you. I don't know whether there are other comments. Yes. The president wants to talk to us.
Thank you. If I understand very well, we're talking about management of burns as it affects the medical laboratory scientists or as it affects the hematology scientist. When there is a burn on the skin, bones, the protein will denature. And once the protein is denatured, there will be coagulative necrosis. The coagulative necrosis will bring about aggregation of platelets, which directly affects us on the hemostasis, the hemostatic values, especially the platelets. The platelets are of so much value in burns.
Thank you so much. Moving away from burns, we want to look at transfusion medicine, the role chances for patients undergoing chemotherapy. So we want to look at our role in supporting patients who are going through chemotherapeutic treatment. Thank you.
For them until they now had something that was suitable to cut across majority of the people. So any patient on chemotherapy most often has challenges because of the cytotoxic effects of the medications, and it's our responsibility to measure suitable parameters to now know how they are progressing or whether they can discontinue that. Thank you.
So we see that the lab plays vital role in helping patients who are undergoing chemotherapy. The reason is this, that therapeutic treatment is very toxic. So it affects virtually all the cells, both normal and abnormal cells. It knocks down the cells of all the cell lineages, the red cell series, the white cells, and the platelets. So, for anyone to undergo chemotherapy, the first step is that the patient will get the full blood count done as a basic. It's a baseline before you can contemplate on administering chemotherapy. And that's for you to know the hemoglobin level, representing indication for anemia, the white cell count, and the platelet count. Having determined the baseline, if patients can carry the chemotherapy, you now start. Otherwise, there will be a workup. There will be a workup. The workup could entail transfusion. This is Another place we play vital role in providing the blood products. The workup could entail administering oftentimes fresh blood. Fresh blood because fresh blood contains all the blood elements. Talk of platelets, talk of red cells, and then if the patient have enough counts, you can now go ahead to administer. And while the patient is going through the chemotherapeutic treatment, the lab also plays vital role in monitoring. Otherwise, you could end up sterilizing the patient. And what do? We still carry out these basic tests. Full blood count. Then you could also look at other organs, whether they have been affected, the kidney, and how do we assess the kidney? You look at the kidney function test. For the full blood count, we are looking at what is the hemoglobin level like, what is the platelet like. Oftentimes we discover that these patients have their platelet level being depleted, and there may be need to give platelet concentrate. So we discover that the lab treatment administration of chemotherapy cannot be done outside the inputs of the laboratory. So these are more what we do. You see, chemotherapy, of course we know, if we had seen someone who is going through chemotherapeutic treatment, you see that not only the blood cells, but all the cells are being affected. There will be alopecia. You see that the hair will be falling off. So, lab helps to rebuild the patients by trying to find out the blood counts, how it is, and how to work up. Thank you. And as we progress, we'll invite our audience, if you have any input to make or any queries that demands attention, you can please draw our attention. Thank you. We'll move away from that, and can we look at how we can address the challenges of blood products shortages and mismatches in our facilities, considering that we are resource limited. We are looking at challenges of blood product shortages and mismatched in our settings, considering our limited resources. Thank you.
All right, thank you very much. If I should borrow a word from one of my big guys here, he said, life is in the blood. And if we all agree that life is in the blood, blood is very, very important in any case of anemia. And addressing the challenges of blood shortage in our environment is a very enormous task, considering our environment. The level of illiteracy here is very high. As we speak today, some people don't even know that blood donation is therapeutic. Some people don't even know that the blood they carry in their system has what we call programmed death, apostasis. After 120 days, the blood dies. So all the wonderful delicacies you are eating, all the good life you are living, If you have not donated blood, you are not helping the society. I want to throw the question back to the audience. When last did you donate blood? Audience, if you have donated blood for the last 3 months, raise up your hands, let us see. How many persons? 1, 2, 3, 4. So you are contributing to the shortage of blood in the society. So I want to encourage all of us to donate blood. As you live here today, make it as a point of duty that you must donate blood at least once every 4 months. It is very therapeutic. It will help you to look lighter. You know, it will increase, it will make your blood to flow very well in the vascular compartment. Let me use a layman's, language. I will allow other panelists to add 1 or 2 things. Thank you very much.
Thank you so much. In addition to what he has said, we know the peculiarity of our climb, but we must find a way of working around it. First and foremost, the onus lies in us to advocate for campaign. We really need to do more in the area of campaign. If people know that blood donation is part of voluntary services, we have a lot of philanthropists. Blood donation is part of philanthropy. If people know that, some people that ordinarily wouldn't have donated blood voluntarily will begin to do that. So we need a lot of campaign, and not just township campaign. We believe everything urban. No. We should not have this mindset of looking at those in the villages as though their blood is not rich, so to say. For your information, some of these people in the villages, if you check their hematological status, you will see that they have more robust parameters than us, which high level, if you check their HB, because those of us in the township, most of the times we eat all the junks and we think we are eating well. But these people eat those things that matter. They eat their periwinkle, they eat their onion, their okra, ugu, all those native things. We just crayfish and are good to go. So we should go to the villages, make that campaign, and aside telling them the importance, we should also demystify the myths behind blood donation. Some customs, they believe it is a taboo to donate blood. And it's one of the reasons why we are having these shortages in our blood transfusion centers. Some people don't want to donate at all because it's a taboo. But if we demystify it, you find out that people will start donating. And beyond donation, because shortages is beyond donation, we have heard a lot about cryopreservation, and of course the advocacies on component donation and all that. And we saw a lot of advantages of cryopreservation, like what Professor AKPOTUZOR advised yesterday, or commented on yesterday, that if cold rooms can work, we can get our ice fish, we can get our frozen chicken. Why can't we cryopreserve our blood products? Let's come down and begin to look in this area and cryopreserve our products, so that, and equally collaborate. No man is an island. The problem we have as a profession is that you just have your shanty lab somewhere and you raise your shoulder high that you have arrived, and you just be practicing quackery. But if we collaborate, you find out that those processes, those technological advancement that is inherent now, that is being practiced in the Western world, we can practice it. And by so doing, we will not run out of blood supply. Neither will we, compromise quality. And aside that also, if we can also improve on delivery, make a way of, having a process in place that can actually make it faster or fast to supply, maybe take blood to the villages, remote areas. It will go a long way in improving patient outcome. Thank you. Let my panelists complete the other ones. Let me not say everything.
Yes, challenges of blood supply in our environment like Nigeria, it's common knowledge. The question now is, how do we overcome these challenges? If you look at the blood transfusion policy, that is the political aspect and policy making, you will see that you cannot draw a policy that will shape in the proper way blood should be either administered, procured, or whatever, without involving the stakeholders that play one role or the other in the system. In Nigeria, nobody wants to involve the medical lab scientists while drawing your policy. 2-3 persons will sit down in one place, draft a policy that protects their interests, and then they go ahead and pass it as a law. So if you didn't ask for my input as a medical lab scientist, how do I now tell you how you can address the issue that concerns my own area? That is one of the problems in Nigeria. If you look at most of the laws that have been passed, not only for blood transfusion, they were skewed to a particular group in the health sector because of their vantage position. So you cannot make a good policy without involving the stakeholders. So to surmount that challenge, all stakeholders involved, from procurement of the blood, advocacy, all stakeholders must be put together so that your various inputs are harnessed, and then the policy will come up to be able to address the shortages. Other speakers have talked about fractionating our blood to have different components so that a single pint of blood can serve more than 5-6 persons. That brings us to the issue of technology. What is our level of using technology in terms of blood transfusion? Only recently, the National Blood Service Commission has come up to say, yes, we have to use ELISA because of the challenges of transmitting infections in our blood. So you are not bringing issue of ELISA today when we have been transfusing blood for how many years? So government should make concerted effort to see how we can bring in technology into the process, so that with that technology we can actually fractionate our blood, so that 1 pint of blood can save a whole lot of people. Thank you very much.
If I don't say this, I will not be happy. One of the greatest challenges we have in this country is power. Power. So as part of the communique drafting committee, we also push it back to government. They should give us what? Power. It will help us to store the blood at optimum temperature. Thank you very much.
Thank you so much.
I want to just say that one of the reasons why we come for conferences like this is to make our inputs. We need, the last conference we had in Port Harcourt, immediately after the conference, the issue of the National Blood Service Commission came up. That is the public hearing of the National Blood Service Commission bill came up in a National Assembly. And this society made inputs. We submitted memoranda and defended it on the floor of the National Assembly. And it will interest you that out of the six suggestions we made in our memorandum to the National Assembly, we got 4 out of it. One of the things we were able to change is that in the bill, it was written that the head of the National Blood Service Commission must be a medically qualified person. But if you see the law now, that law has been changed to something that can accommodate us. It can accommodate us now. They have removed that phrase. They have removed it and then included a phrase that can accommodate us. That was one of the recommendations we made on our memoranda to the National Assembly, and it was approved. So I want to say that we are stakeholders, we are involved. That is the reason why in this conference we also invited the National Blood Transfusion Commission to come and give presentation. He did not come, but he sent a representative to represent him. The man that came yesterday came from the National Blood Service Commission. I want us to be participating. Sometimes we have meetings. We have meetings to draft policies. Our secretary, Muibi, can you stand? Our secretary was one of the policy, the last policy drafting that was done for the National Blood Service Commission. I did not go, but he represented the society. If you look at the policy, you will see his name as representing this society. So we are fully involved. We are fully involved. That does not rule out politics. When it's time for appointment, there is always politics to put who they want. But the floor is open for us if we have the wherewithal to push in somebody. It is so. We can be the Director General of that establishment as it is now, removing politics aside. So that is what information I want to give us. So I'm using this opportunity to encourage us to be part of. After this conference, we are going to develop a communique. The last one we did, we published it in national dailies. We published in national dailies. We circulated it. We even sent some to the House of National Assembly, to make sure that our voice are being heard. So we hope to be doing that from time to time so that people will hear our voices. The truth is that if you don't blow your trumpet, they will not only blow it for you, they will take the trumpet from you and blow it the wrong way. So rather than waiting for somebody to blow your trumpet in the wrong way, why not blow it yourself so that you can tell the people whom you are and what you can do. Thank you.
Thank you so much. If you don't blow your trumpet, some other person will blow it for you the wrong way. And part of blowing our trumpet will entail that we really have to, one, see a way to demystify this myth that blood donation is not healthy. And then we'll come up with slogans, particularly on our World Donor Day. We can go to the media houses to tell people that they can donate blood today and save life. Things like that. We can embark on donor drive in our various facilities. We can organize ourselves and launch out to sensitize people to see the need to donate blood. Thank you so much. Someone is raising his hand. Yes, Dr. Ataya Christian. Please come forward.
Thank you, ma. My name is Dr. Ataya Christian. I just want to contribute and also to throw a direct question, maybe straight to our second panelist, Dr. Ben, as a form of advice to be given to me and maybe others that might be in this situation I want to paint. I came across a group of persons in my facility, and there was an opportunity to tell them on the need to donate blood. Just as you gave some benefits, I did. In fact, that was a good lecture for them, but there was just one problem, and it was difficult for me to convince them to donate. I would have gotten 20 pints of blood, and I would have brought them to Federal Medical Center here. But the one question is this: they said, how will I convince them that that blood they are donating will be freely given to those that are needed? It was very difficult for me to convince them, and they refused to donate. So, sir, if there is any way you think I can put it, please tell me. Thank you.
Okay, thank you very much. Blood is a free gift from God. But to make that blood clean for the recipient is another kettle of fish. So when somebody donates blood, he or she should know that that blood is a gift from God. It is flowing in his or her system and will expire after 120 days. Now, the workup is where money is being spent. You know, because that's the challenge most of us have when we are going for donor drive. Some of my colleagues have been beaten blue-black when they went for donor drive. You know, as they were able to convince some of the donors, but some commercial donors who have been making money out of this business landed some heavy slap. He said, you will go and collect this blood now and go and sell it. So the answer to that question is that if you activate 4 channels ELISA, for instance, tell them the cost of making this blood pure, because you don't collect the blood from the donor directly to the recipient. There are some workups we do, and these workups cost a lot of funds. If you explain this to them, that what the recipient will be paying is for the service charge of, first of all, screening the blood for TTIs and also making the blood compatible for the recipient. I think you are good to go. Thank you very much.
Yes, I just wanted to say something in that regard. You are dealing with an illiterate whose mode of thinking is one way, and he tells you, I give freely. Why don't you give freely? He's going to ask you, if I can donate freely, why can't you test that blood freely? So the bottom line is advocacy. Because those your explanation, you TTI, ELISA, he doesn't hear that one. Okay? He doesn't hear that one. But by the time the advocacy is intensified, some of them can be made to participate in the process. Invite some of them, let them see what it is. Maybe by projecting a process from the sample collection, from the blood donation to the finish line, they will see what and what is entering. So the call should also go back to government. If we must encourage availability of blood, then government should also bring most of these materials as a subsidized rate. If government can spend millions to maybe tar a road or sink borehole, why can't they provide those materials even for free? Because when HIV started, the US government provided money, okay, and HIV test was being done free, and people volunteered to come and test themselves. So because of the crucial nature of what blood is and what it stands for and the life is going to save, then our advocacy should also go to calling on government to highly subsidize this testing that is done to make the blood pure. That way, the donor will see himself contributing to the flow, the supply, and then you on your end, it's actually putting in the technology provided freely by government, so to speak. And then at the end of the day, the blood could actually go free. In Delta State, we had this free maternal program that was championed by government. And the policy was every pregnant woman is entitled to 2 units of blood that is free. What do? You document everything you have done and you send the bill back to government. So government paid for it. So every pregnant woman was entitled to 2 units of blood. So imagine if that can be practiced across the whole country. You will see the number of persons that will benefit. And then the person donating will say, yes, my brother's wife went to the hospital and they gave her 2 units of blood free and we did not pay. So I will donate because somebody will also benefit from that. Thank you very much.
I want to chip in something. That aside the government subsidizing or even making the screening process and the compatibility testing free, facilities we can also reach out to philanthropists. We have organizations like Rotary. If such organizations are reached, they can bring money that can actually, pay off for those screening processes. And at the end of the day, the patients, particularly the indigent patients, get those blood free. Thank you.
All right, thank you so much. We have a hand up. How many people want to ask questions or contribute? Please, can you come forward so that in the next 3 minutes we are through with this section? Please do well to come forward. As many that wants to make comments or ask questions. Thank you so much.
Standing on the existing protocol, I'm Scientist Vivian. I'm coming from University of Calabar Teaching Hospital. There was a practice that goes on there. So each time you come to bank, we have blood. What they do there is this. They will tell you, save a life today and be saved tomorrow. That is what they practice there. As long as you are a donor, when you donate, there is this net that they normally give you. When they give you that paper, if you present that paper anytime to that same clinic, you are not paying for blood. Hospital gives you or your relative that blood. The one that you've given, any day you are in need of it, they give it to you back. So that's what I want to say.
You're not paying for the blood or for the services?
As a donor, when we go out for blood hunting, we go with that card. So when we bleed you, you screen and bleed. Once you are through, as in you pass everything, they hand over that card. That means your blood can go. They hand it over to you. So hospital takes responsibility of whether you call it, you are a free donor. We are not charging you for anything. Yes.
Thank you so much. So you see that some other institutions can decide to practice that.
My name is Dr. Fred Wiko. Coming from the private sector perspective, you see, when we talk about this blood drive and blood donation, most times the public centers cannot service, or there will always be shortage if we depend on this. And as med lab scientists, the policies we run now discourages remunerated donors. We always say free donors. But from the private sector perspective, nobody, no donor will come for free. Except you pay them, they won't donate a pint of blood. And if we depend on the public sector, we will always have issues. Because at times, even you see people come from, moreover when it has to do with resource negative blood, you see people come from government hospitals to the private labs to source for blood. So I think while we create these policies, let's begin to think of how to remove that fact where we keep saying no donor should be paid a dime. Because if we keep doing that, we may not be getting it right. Let's begin to think about it. For the public centers, I know that you have blood drive, blood donor day, but I don't think any private lab will just enter a community and say we are looking for blood donors. I don't even think that the act permits that. So let's begin to look at it to accommodate the private practitioner in this blood transfusion thing. Then secondly, in the last conference, I remember there was this issue of ELISA screening for transmittable diseases. But in the private practice, most of what we see is a doctor says, I want today blood. If you don't have today blood, don't give me. I want today's blood. And there are some of these things that are challenges we face. How do we accommodate it in course of our practice? Thank you very much.
I think Dr. Ajekuko has said it all. Advocacy, advocacy, advocacy. If I use the Lagos State government template, anybody from Lagos here? I always talk about Lagos State government. There is a law there passed by the Lagos State House of Assembly. You cannot give out any unit not screened with ELISA. If you do it, you go in for it. That is for Lagos State. And they have gone for advocacy in such a way that let me say Lagos is an enlightened society. If they go for advocacy, most times they even chase people away, people that come to donate freely. So it's very peculiar to some societies. By the grace of God, we will get there. Thank you very much.
Yes, I just want to give a scenario. WHO say TB testing is free. And you see them putting in measures to the extent that private laboratories are involved in TB screening. Who pays for it? The money comes from that system, not the patient. Okay? So as part of advocacy, if the private laboratory gets his or her ELISA testing materials free from government, and then for anybody you screen, you send the information back, government or the agency or the intervention can pay for that service. That way, you as a businessman, you are not losing anything. So if we take the model of TB screening testing in Nigeria and apply it to blood transfusion, I think it's going to work. Because I cannot buy my reagent expensive and do a testing and then you say I should not charge money. So if you don't want me to charge money directly, then I will shift the cost back to you. So if I provide you with all the materials as government, and I say for the workmanship of bleeding the donor, for every one you collect so amount of money, and then you actually document that in this month as a private practitioner, I bled 20 donors. I screened them with the material you gave to me. and I handed the blood over to so facility or center, as the case may be, and the documentation stand there, and for each unit I'm supposed to be giving amount X, you multiply it by that 20 units and I collect it. I think I want to encourage that, because at the end of the day, it was only the workmanship that I did. Every other material was added to it. So let's see how we can use this method and see if blood donation could be better. Thank you.
Our time is almost running out, so please be brief, and even in our contributions, make it snappy, punchy.
Good afternoon, all. Mine is like a sort of something I see as a challenge, you know, to see if it's the right practice or not. I think we had a training sometime in January or February conducted by River State government. And in that training, we had the director of blood services from the Armed Forces Blood Center. And we were made to understand the goal of blood drive, and they could get as much as 300 units of blood. And because blood is being collected without screening, each blood drive that they go on, they don't screen. They collect as much as they can, then bring back to the center, then begin to screen, test with ELISA. So in that process, you find out that we may have like 300 units of blood, and at the end of the day, you find just 50 that will be useful, and others will be destroyed. So I don't know, is there any how we can actually, you know, sort this out? And secondly, so that we will not be caught unawares, we also rapid test kits, RDTs, then you're going to be a culprit at then. So I don't know, we should also.
It's okay. What I just want to suggest is what my name is Dr. Emmanuel from Federal University of Turkey.
Profoundly important in choosing hematology and blood transfusion science. There is a question on in what ways could hematology curriculum be improved to address the needs of students. And majority of the students agrees that continuous professional development, mentorship and collaboration, comprehensive program evaluation is very crucial, is very important in improving the curriculum of our students in various universities. In conclusion, the survey concludes that hematology and blood transfusion science is a popular specialty of choice among undergraduate students of Ayutthaya University, Ilorin, which is majorly influenced by their passion and mentorship. There's a very high need of interactive seminars and student-teacher mentorship in the institution, and there is a low student-clinician collaboration during laboratory clinical posting, and a below-average use of LIMS. It is hereby recommended that the use of LIMS be improved, and that interest in HBTS be built up through mentorship, collaboration, and more fact-finding studies. Thank you for listening.
Thank you so much for that presentation. We will now call for comments, questions. Do we have any question for her? Are there comments? Please, if you have any, please come and sit this way. Let's be brief. No questions. Can we allow her to go? Thank you so much. Please, let's clap for her. This flash is it. So we will call the next presenter, and that's what's his name again? COVID. open it. Let me find out. For his presentation on evaluation of blood supply and usage pre and during COVID pandemic. Thank you. 10 minutes.
10 minutes. Thank you, ma'am. Good day, my senior colleagues and colleagues. I stand on an established protocol considering I have limited time. I'm here to present the topic which says evaluation of blood supply and usage pre and during COVID-19 pandemic, a lesson from non-voluntary donation. These are my co-presenters. Next slide. As a means of introduction, on the wake of 31st December 2019, the Chinese government woke everybody up by reporting to the World Health Organization that there's a novel disease that presents a pneumonic pattern. Then exactly the WHO group went on to search, and finally the disease was termed COVID-19, and the causative organism was termed SARS-CoV-2. Then the first case, in this case of Nigeria, happened on 27th February 2019. Yes, sorry. Then the pandemic actually affected all spheres of life due to the lockdown, economic aspect, and including blood transfusion. So considering all this, we intend to study, we studied the effect of the pandemic on blood transfusion in our institution. Aim of study. Sorry. You're faster than me. Okay. The study tends to assess the effect of COVID-19 pandemic on blood supply and blood transfusion in University of Calabar Teaching Hospital. Okay. Methods. We use the descriptive cross-sectional method. Then we also apply the retrospective collection of data from a BGS laboratory and donor clinic. And this data consists of the number of donor, number of requests made, number of cross matches made, and number of dispatch units. And this information we are collected from donor registrar and the rest. Then our method, we collected the donor data from the donor clinic, while request, cross match, and dispatch we are collected from the blood group serology laboratory. These are the definition of terms in terms of the things we used. Pre-COVID period refers to cases on or beyond or before March 2020. And conveniently we chose August 2019 to February 2020. Then COVID-19 in this case was reported on February 27, 2020 as stated earlier, 2020. Then the period of COVID-19 is the period from March onwards. That's the time referred to as the during COVID period. Next slide. Okay, then for benefit of doubt, voluntary non-remunerated blood donors refers to those who donated blood without receiving any form of payment or compensation. Then family replacement donors was reported in Saudi Arabia, but as opposed to the results reported in Western countries. And this gives us, this pattern we saw here is a typical pattern of hospital-based blood donation, whereby there's a tight gap between the request and the blood donation, showing that once the blood is requested, the blood is provided. And it's a typical occurrence where you have a donor pool dominated by commercial donors and family replacement donors. Okay, this brings us to the discussion. There's no actual difference between the donation and Africa, which related from the West. Till today, it has eluded us. Next slide. Next slide. Okay. Next slide. Almost done. Okay. So, by way of conclusion, our studies have shown that during the pandemic period and possibly in future pandemics, that people who donated blood, either for commercial or to save family members, defied the lockdown to still what? Donate. Unlike in Western countries where people who voluntarily donated blood went out of their way, refused to come out for the risk of contracting COVID-19. 12.
Last presentation here, comparison between the second treatment group and third treatment group. That is, those values at the end of the 4th month of treatment and the values at the 6th month of treatment. They were highly insignificant here. So, after going through the study, we find there was nothing that this one didn't take drugs today or this, that.
Of your question, let me just add up to his answer. Now, I've also been involved in TB case management due to the fact that I run an NGO. So I get to know that for TB patients, it is very difficult for the patients to abscond from treatment because they have a treatment regimen that they are strictly following. And the case managers, they also have an incentive they give to these people. So you don't have any option not to come for your drugs. Sometimes they made it a way that at some stage, they will give you transport so you come to the clinic, to the health facility to access your drugs. Because if they give to you, you might stay at home and won't take the drugs. So they try to create means in which they can always attract you to come and take.
Somebody who will not want to come and take the drugs will not take it, because we actually have cases where plus incentives, they don't come for different reasons and they die. So I think even incentives, people can still leave it. So that's.
Did you get the question?
I got it. You are asking whether we compared somebody that took the drugs at the end of 2nd month. We compared these values to when it was the end of the 5th month. Of course, we did. We did ANOVA, and then a lot of this thing followed. What do we call? After ANOVA, what is that thing you bring out? Post-hocs, yeah. A lot of post-hoc came up, but I only brought out values that were significant, very, very, that is of interest. I brought out the tables that are of interest. Otherwise, you will see the whole, you can see here now. You see control and third. You see 2nd treatment and 3rd treatment. They were all compared. You see control and newly diagnosed. You see control and 2nd treatment. So all those comparisons, they were all made. They were all made.
Thank you so much, Christian. Thank you. Please, can we clap for him as he takes his seat? We will now call up another presenter, Beatrice Moore. How old? Okay, she will want to look at the impact of ibuprofen, diclofenac, and piroxicam on full blood count of Western albino rats. 10 minutes.
Of nucleosides. Comparing our work with the work carried out and maturation, Okay, let's continue. We have the third group, which is the ibuprofen treated group. Looking at the cells, the slides, slide A shows hypochromic podocytes. These podocytes are target cells that are void of hemoglobin. They have reduced hemoglobin, and they are suggestive of hemoglobinopathies, which can result in either thalassemia, sickle cell anemia, and can cause a lot of other health challenges. We also have here the presence of macrocytic cells and podocytes here, of course, which suggests that ibuprofen may interfere with normal erythropoiesis. So when ibuprofen is
evaluating the effect of the drugs on those parameters in the animal, your standards are also animal, the animal control, isn't it? So it's between the animal control and the subject's animals too. Okay, so that is why the human
experiences. Thank you so much. Thank you for your presentation.
Thank you, Prof, for your advice too.
Do we have other comments to make? My dear, you can sit. So we allowed them all this time because the other presenters didn't show up. Some said they are coming tomorrow. I doubt whether we can accommodate them. If time permits, we may. So that brings us to the end of the scientific session. I want to thank all the presenters and want to thank everybody for listening to those presentations. Thank you. Thank you. Thank you.
Ladies and gentlemen, we've had a very wonderful session. We've had a very wonderful section. I promise you every one of us did enjoy the section of today because it was quite brainstorming and brain racking and also brain mending. I learned a lot. But before we call the next person to give a talk on World Hemophilia Day, I sincerely want to also remind us that we are all hematology inclined and we know what thrombus is. So I will just say, let's do a little. When I was much younger, I was leading a special number in the church. I'm a very good singer. And there was a day I was called on to give a special number in church. Please, ladies and gentlemen, can we all rise up? Hello? Can we all be on our feet, please? Please, can we all be on our feet? Can we all be on our feet? I just want to tell us this afternoon that I was a very, very good singer in church while growing up. And on that fateful day, I was called to give a special number in children choir. And when I came out, I handled the mic. And then I started thinking the song I had rehearsed a few days ago. Lo and behold, what came up to my head. Please, when I say, just follow me. And I looked at everyone. They were expecting me to sing. Then I now did like this. Everybody do like this. 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 Anyhow you want to fling your hand to just. How do you feel now? How do you feel now? And that day they thought all what I was demonstrating, they thought I was trying to, in church when you want to lead chorus, you raise your hand and say, spirit. Now then they try to remember the song. So we can now sit down. Ladies and gentlemen, let's call on George Joy, let's call on Joy to brief us. Oh, no, I know. I've not eaten beans since this conference started. So she will just give us a little talk about the World Hemophilia Day coming up. Thank you.
Good afternoon, everyone. I sent somebody to give you. That's just that balance. You know, and culture abandoned some people in our localities. Where, you know, those days when somebody has sickle cell, they will say it's Obanje. Yes or no? And the same thing is happening to the matter of hemophilia. I just told them to put, this is what is happening in UPTH Port Harcourt, from where I'm coming from. In collaboration with the Hemophilia Foundation of Nigeria. I just wanted to put so that especially those of us that are students and those of us that are not really aware that something like this could see. I just wanted to look at it down and always also the date that every 17th of April has been dedicated to celebrate Hemophilia Day, World Hemophilia globally. And look at it down, because if you recognize those places, you will see that if you are not knowledgeable, you don't know your clotting profile, your profile, you may go for teeth extraction. A child is born, 8 days is being, what do they call it, circumcision. You can also go for different things, surgery and the joint, the bleeding, where all these things can take place. You can see from the nose, under your skin, from your joints. I was searching for a picture to show you, and it really broke my heart because of that child. This child had a joint. They thought the child fell from school. The child was, you know, they invited somebody to massage. Before you know, the child's leg was 4 times the joint, so big and destroyed. The more they were massaging, the child was bleeding into the joints. The more they were doing, the child was bleeding into the joints. And if not for God, that child's leg would have been amputated, a little boy. So these are things we have to know, that there's something called hemophilia. So that when you, as a scientist that have a living mind, what make us scientists, our minds are active and living. We are always question everything. We don't just apply it to spirit, to culture, to tradition. That is what makes us to be scientists. So especially for the sake of the students here, when you see a little child or somebody around you, a woman, man, and you look at patches on their skin, and you see some people, you think it's not bleaching, you will know that that person is bleeding on that skin. You see all of a sudden a child running around and you see the joint begin to swell, having patches. My dear, it may not be a fall. I know sometimes the kids will tell us, Mommy, I didn't fall. You need to, inside time, you go to the hospital. And that brings us to tell you that it's not recommended. I just want to touch 1 or 2 places to make you become aware that there's something like that. That it did not start today. Since from the 2nd AD, after the death of Christ, this started. But when did it really come to light? It was in the 1800s. A man called Lee had a son, and it was then this thing started manifesting. And they begin to say, what happened? They took him to the doctor, they call it different names. And then it was not even called hemophilia. It was called Valibran disease. That was what generally it was called. I hope you are hearing me. Until now that it has been differentiated to the consequences of deficiency of factor 8 and 9, which make hemophilia A and B. The B is also called Christmas disease. So when you are hearing, they are real. That's why I brought this to you. I did not really talk with the foundation, the CEO of the foundation. I would have want to send out those pictures so that you believe. If I had spoken to her, gotten her phone, you see me going up and down. I was trying because I wanted to show you that there are live people suffering these things. Now, I've told you, there are different types. Although recently, a 3rd one is also added aside from A and B. The C or the Van Valibran disease is also accepted as a number 3 of hemophilia. And what are the things? Factor 8 and factor 9. So normally they are assays, but PT and other ones are just indications. And by this we are advised that once you have a child, take the child to the hospital. Especially when you yourself, after now every scientist, go and do your PT. Don't just run the test for people. Say routine thing we should do. And on the palm of your hands, of mind, you should know what your clotting profile is. Before you marry, do it. Not when tomorrow your wife, especially the young people here, you say my wife is having a baby, before you know, all of a sudden. Even like our brother will say, the doctors that even are aware, because they are not in that area of specialists. They don't know. You just bring 16 pounds of blood, bring 10 pounds of blood. The date, are they not supposed to, before a woman going to delivery, take this home, those close to you, tell them they're supposed to check their PTs, not just for surgeries, even for delivery, even if for a minor circumcision. So it is recommended that when you have a child, whether you know your history or not, take the child to test for the child's clotting profile. So that from childhood, then you also check your history. Like I was saying, that was what happened. But what are the things? I'll just share a few things with you. How do you know that you have? But before I go there, I will want to let you know it's a sickness that normally passes from a woman to a boy child. But to tell you now, of 2024 recently, from findings, women are also, they are normally termed as what? Carriers. Just before I came here, I didn't even know, this thing just came to my mind. I was going through something. I said, the CEO herself has been termed over how many years as a carrier. But just before this World Day, she has to give up all over the world that she is what? Also a bleeder. Because it has been managed, and unfortunate for her, she passed it to her children. And that was what inspired her to go around the world to set up the Hemophilia Foundation of Nigeria. You can connect with her. I want everybody to connect. She's an open-minded person. And it's funny, she's a nurse by profession. But because of the passion, the concern of a loving mother, seeing her children suffering, every time they are wiggling in pains on their joints, and their brain, in their nose, mouth. So she went in. And today, by virtue of this woman called Megan Adediwe, if you go to Facebook, even I think she was live in the morning. She is the CEO of the Hemophilia Foundation of Nigeria. She has been seen as a carrier. But the thing is that she and few others I know, we are unfortunate, because normally it is in 1 in about 500 that this thing comes. But the prevalence has changed. I can, just like sickle cell, normally it's a 50-50. Imagine that, and somebody having 3 children. I have one. By the time our second son died, she is the one heading the Port Harcourt Hemophilia Foundation. The husband left her, just like I know a young lady, first class lady, Ibere, those that went to USD. She was living under our staircase. She was a sickle cell patient. Came out with first class in banking and financing, a bank of a bed. Because of her condition, the parents abandoned her in the hospital. The parents abandoned. It's a really bad thing. Something we don't know anything about. A child will come to this world without knowing anything, and it's touching. The father of this woman left her. The person heading this Hemophilia in Port Harcourt, our focal person, left her like that, and only her single-handedly suffering with those children. And then the factors were, what did they call it, imported. It will go to Lagos, then it will now come to Port Harcourt. But I thank God. Why I say connect? By the time you start seeing those signs, you can see somebody bleeding from the eyes, from the nose, without even extraction, having swelling joints under the skin. Then sometimes in the brain, you see the person having constant headache, bloody eyes. You will know that there is something wrong. That's a missing factor leading or causing hemophilia in that person, though it has not been typed to know the actual one. So that's why it is recommended that as we leave here, everybody try to know, go and do these things. It may not be always just for you to know your status. Also, when a new child is born at the infant stage, or when the child is like 3, 4 to 6 months, try, or to 1 year, so that you can quickly know how to manage the child. And what again, like I told you, that what are the things you are supposed to do? I've just told you one, to go and make a check when a child is born. Sorry. these are the 5 things you can do. That every time in a year, you can get an annual comprehensive checkup at any hemophilia center or even in the laboratory. We have one in Port, but you can just do the routine test for a child. Especially when you go, begin to ask questions in your family. Like I said, women, we are not. They were termed as carrier, but even women are what? Bleeders. They are called bleeders. So not just transferring to boys. You could be recessive in the grandmother, but maybe by their own time, it could express in little way. Maybe after giving birth, the bleeding wouldn't stop. They will tell you one thing or the other. So what are you supposed to do? Go for a comprehensive checkup. Sorry. Then also get vaccinated, because sometimes there are predisposing conditions like hepatitis, other things that can lead to that kind of situations. So get vaccination to necessary diseases. Then treat bleeds early. The one you cannot stop, please rush to the hospital. And again, exercise and maintain a healthy weight to protect your joints so that bleeding will not go into them. And then get bleeds early and get tested regularly. Thank you.
Ladies and gentlemen, that was a very wonderful information. Please, any additional information you will need as a result of this, kindly meet our mommy there. I call her mommy because I was a little boy during my hospital posting when I got to know her, so I can call her my mommy. Yes, for all the young medical laboratory scientists present here, the Bayelsa State branch of the Young Medical Laboratory Scientists Forum of Nigeria, they want to host you. So please, there is a list going round. If you're from any other states, you're not from Bayelsa, and even from Bayelsa, please put your name on that list. It is important that the branch executive, they want to welcome you and also identify with you. It is very, very important. I also have 2 lists here with me. It's the list for hotel. If you know you stay in either Peretimi Hotel or Ubena Hotel, please put down your name on this list so the accommodation committee can do a little follow-up on certain issues arising from that hotel. Then our next item will be announcements. We'll call on our president to give us announcements and a follow-up of activities for tomorrow. But before I call him, please prepare your hands to put them together while I call him to the mic. I want to fulfill the promise of 50,000 naira, and nobody yet has come to me to give me the answer. But I want to tell you, let it be a privilege to you that while you attended Hbtssn conference in Bayelsa State, you got the knowledge and additional knowledge home that the language, the African language that was spoken in the Bible is an Azor language. And you will see it in the book of Daniel 5:25 that says, Teke, Teke, Mene. If you want the meaning, please come and meet me and I will explain the meaning biblically. Thank you very much. Let's put hands together as we call on our president in the person of Professor Z.A. Jeremiah. Okay, let's call on the General Secretary, Professor Musa Muyibi, for announcement. Welcome, sir.
Thank you so much. Good afternoon, everyone. Good afternoon. Are you hungry? Okay, we are there to the SOP. I think we are going for the meal now. Before the scientific committee will address us after. Or you want to address us before the meal? Because tomorrow something unique will be happening here. And that is hands-on on use of coagulometer to run coagulometry. Definitely it's only going to be for, so it will be starting by 9 in the laboratory here. Where is the lab? Prof, sir. Where is the lab? Wait to the lab. Okay. Where is the laboratory?
Molecular biology lab.
Okay, so we are doing the hands-on by 9 a.m. tomorrow at the molecular laboratory. Yes. And so many things we have learned here, and one of the features of this conference is that we are doing workshop and we are doing hands-on, and that's hands-on. All the reagents except few, maybe one or two, they will be provided by HBTSN. The reagents and the equipment are solely provided by HBTSN. So let's appreciate HBTSN. Even the trainers will be coming from HBTSN, and they are going to first do what they call a pre-analytic talk, and everything commences by 9 a.m. Please note that. And that workshop, the workshop we are doing today, plus that of tomorrow, and the support is from the support of IS. Okay, HBTSN is there now. No, ISTH is providing support in terms of all these award that people will get. But the reagent, machine, and trainer for hands-on tomorrow is strictly from HBTSN. So we have appreciated you. So 9 a.m. please, let's see there tomorrow. HBTSN is moving with the trend, and that is where we need to be. Okay? So some of us now, for instance, we don't even do PTPTK at all. We are not talking of use of coagulometer. When we get there tomorrow, we learn more. Thank you. President, sir. And the scientific committee, nothing today. I don't. Okay. So, I think we'll be going for the lunch MC. So because we are long ground, we go for the lunch with our meal tickets. Let's go for the lunch. We are not. We are going to the molecular lab tomorrow at 9 a.m. So thank you. Are we closing? You can close. Come on.
Ladies and gentlemen, today it's been wonderful. Today has been great. And I sincerely want to appreciate every one of us that actually stayed back to follow up all activities and items on today's agenda. Like our General Secretary said, please tomorrow let's come for the hands-on. And
Obviously. And we also thank you for the ones we are yet to have. Father, we pray that at the end of the day, you will make our participation in this conference memorable to the glory of your name. As we go back to our various destinations, Lord, may you see us through. And even those that are yet to come, may you guide them through, grant them journey mercies as they come to join us. Thank you, Lord. Even the food we are about to eat, Father, I pray that the food will nourish our body to the glory of your name. Thank you for the provider. Thank you for all our sponsors. The Bible says that givers will never lack. And so shall it be upon each and every of our sponsors in the mighty name of Jesus. Thank you, Lord, because we know you have answered us. For we have prayed in Jesus' marvelous name.
thank you very much. So please watch yourself, go with your tickets. Let our elders take their food before we continue with every other person.